Alaikum. Assalamu alaikum. Welcome everyone to the second day of ERCP workshop. A relatively boring start, but let's hope it's interesting and important one for all of us. At the 11th hour, Novel made me deliver this talk. It was Novel who was supposed to deliver this talk. So, okay. Yeah. So it's very important. The aims of today's talk include the basics of electrosurgical unit and some basic terminology, types of circuits that we use in endoscopy unit, major modes, some important aspects of ERCP related to diathermy, and some special considerations. Now, this is one of the example of a basic circuit and with a generator, electrosurgical generator, that's the source of voltage, a device, in this example, a snare with the target tissue, which is also the site of resistance. And depending upon what type of circuit is this, either monopolar or bipolar, in this case, a monopolar circuit. So we have a dispersion pad to complete the circuit, to take the current back to the electrosurgical generator. We'll discuss further. Now, this electrosurgical unit turns regular electricity into high frequency energy. Why regular electricity is not used in diathermy? Because with the low frequency current available in regular electricity, it can stimulate neuromuscular system and can lead to shock, arrhythmias, and neuromuscular activation. The high frequency current, on the contrary, cannot stimulate the nerves. That's why it's used in electrosurgical unit, and it produces heat instead, the thermal energy that leads to the desired effect, either cutting or coagulation. So we have three different types of waveforms: the cutting current, the blended current, and the coagulation current. Obviously, if there is rapid rise in temperature above 100, it will lead to a cutting current. If there is a gradual rise in temperature and it's between 60 to 100 degrees C, it's a coagulation current. The blended current is in between. We will see some other factors too. Now, if we look at the effect of temperature on the tissues, it's at around 40 degrees C where tissue edema occurs. It's usually reversible. After that, if, as I mentioned, that temperature rises beyond 100 degrees C in a sudden manner, it will lead to cutting effect. And if the temperature is between 60 to 100 degrees C, it will be a coagulation effect, provided that this is all done in an insidious manner. If we look at how sensitive our GI tract to the effects of diathermy is, we can see that right side of the colon is the most sensitive one, followed by duodenum and small bowel and transverse colon and others in a descending manner. So as we just discussed, there are three types of current: pure cut, when there is sudden rise of temperature above 100, and the pathological mechanism here is cellular vaporization. On the other end, we have coagulation, pure coagulation, where the temperature range is between 60 to 100 degrees C. And the pathological mechanism here is cellular dehydration rather than vaporization. The blended current is in between. So these are three important waveforms that we will be seeing later. Now, there are some basic definitions that are important before we delve into the clinical aspects of diathermy. Current, we all know it's the flow of electric charge. The resistance means the opposition to current flow. If we take this into clinical perspective, the tissues that have got high water content, like blood, will have least resistance, while bone, fat, they will offer high resistance. The same happens to fibrosers and scar tissues. They are the source of high impedance. So sometimes scar tissue build up on the devices. That is also one of the reasons which blocks current and increases the impedance. Now, there are three essential concepts that determine the outcome of the current, whether it will be a cutting current or a coagulation current. Number one is voltage. In fact, the peak voltage, the duty cycle is an important concept, and the crest factor. Voltage, we all know that it's a force that pushes current through the circuit. And peak voltage, as I mentioned, is the most important factor. So if a high frequency current goes above 200 peak voltage with a rapid rise in temperature that will generate a cutting current. There are some examples of high voltage coagulation modes as well. We will see like forced coagulation, swift coagulation, spray coagulation. We used more in third space endoscopy. So again, the basic relationship of voltage with current and resistance. If the voltage increases, automatically the current increases. But when there is more resistance, the current will decrease. But to overcome that resistance, we need to increase the voltage. Second important aspect that determines whether the current will be a cutting current or a coagulation current is duty cycle. That simply means the percentage of time the current is available in a circuit. The simple concept is if there is 100% of the current available, 100% of the duty cycle, it will be a cutting current. If there is 6% of the duty cycle, it will be a coagulation current. The lower the duty cycle, the more coagulation it will happen. But it's not just the duty cycle that defines whether the current is a cutting current or a coagulation current. We have to understand the importance of peak voltage here. A voltage above 200 means the cutting effect. With a voltage around 200 in a gradual manner, it's usually a coagulation effect. The graph shows the same thing as we see here. Pure cut means 100% of the duty cycle. On the other end, extreme end, we have coagulation where the duty cycle is least, around 6%. And in between, we have blended cut, blended crans. The third important factor is the crest factor. Simply means peak to average power ratio, the ratio of maximum to the average amplitude of the current. So the simple concept here is cutting current has got a crest factor of 2, while coagulation currents usually have a crest factor of in between 7 to 8. Now, looking at two common models that we use quite often in our endoscopy units, we can see how these three important factors, the voltage, the duty cycle, and the crest factor, implies what current will be activated. Like if a voltage is in between 50 around 200, it's usually a soft coagulation. With relatively high voltage, we will have either endocut or coagulation currents. If you look at duty cycle, which means the percentage of the time percentage where the current is available, 100% duty cycle implies a cutting current, while a lower duty cycle means that it's a coagulation current. As we just saw, a crest factor below 2 means cutting current, and above that, it's usually a coagulation current. So same happens here too. Another concept is current density. I think it's very important. It just means current per unit area of the electrode. Now, if there is a smaller contact area, like the tip of the needle knife, that means the current is concentrated at a very smaller point, and this will lead to rapid sharp cut. Hence, that explains the risk of pre-cut papillotomy. There are different factors that defines current density. Obviously, the voltage, the size of the electrode, the resistance in the tissue. This is very important. And obviously, the duration of current. As I just mentioned, that if there is a small electrode or small device like needle knife, the current will be concentrated at very small point, but then it gets dispersed over a much larger area if it's a monopolar circuit because of the grounding pad. So therefore, on one end, you have a very high current density producing either cutting or coagulation effect in the tissue, but on the other hand, the body temperature does not rises because of the dispersive pad. So next important, we always hear either it's a monopolar circuit or bipolar circuit. So when we say monopolar, that means current will pass through the electric electrode through the body to the target area and will exit the body through a dispersive pad or a neutral electrode to complete the circuit. But in bipolar mode, the endoscopy device contains both the active and neutral electrode, and there is no need of dispersive pad or neutral electrode. So again, the picture tells us very clear that in monopolar circuit, we have a dispersive pad to complete the circuit, and in bipolar, we don't need a dispersive pad. What are the examples of some monopolar devices? Hot biopsy forceps, snares, APC, and some hemostatic forceps. while bipolar devices usually include RFA. Speedboat is a new device used in POEM especially. That's also a bipolar device, and Gold Probe. Coming to some major modes, obviously the modes are either pure cut modes like auto cut or high cut, blended cut modes, which we now see quite often, the endo cut Q and I, pulse cut if it's Olympus, the coagulation mode we will see, and some non-contact coagulation mode, which include APC and spray coag. So coming to cutting modes, we commonly use endocut Q and I or pulse cut slow or fast. Now they have got blended effect. That means cutting and coagulation both will be there. There are some important modifiable parameters on the screen whenever we use a cutting mode. One is effect we will see, which is the amount of or intensity of coagulation, the duration, which is the amount of tissue cut in one go, and interval, that is obviously the duration between the two cut cycles. So this is one of the examples of the screen in diathermy that we see quite often. So the first thing we see is mode. So mode is either endocut Q or I. Now looking at the shape of the Q, it looks like a snare. So that is used for snare and hybrid knives. But if you want to use needle knife or do papillotomy, then we will use endocut I as the alphabet shows. This is a typical blended current with cut and coax cycle in between. Another aspect or modifiable factor is effect. Now, effect means the amount of coagulation. The more we will increase it, the more we will have coagulation. So setting 1 means pure cut. On the other hand, setting 4 means more and more coagulation with blended current. The second thing that we see on the screen is duration. Duration is the amount of tissue cut at one point. So setting 1 means a small cut, and while setting 4 means a deeper cut. Interval is another thing that is seen on the screen on cut mode. So interval is just the duration between the two cut. So with each increase in the duration, there will be 160 millisecond interval increase. So that will give time for coagulation to happen. So effect and interval both helps include the coagulation component, while the duration is just the amount of tissue that is cut. Now coming to some coagulation modes, the forced coagulation, swift coagulation, spray coag, soft coag, and power coag. Now, soft coag is a pure coagulation mode with a voltage of around just 200. It has got no cutting capacity. That's why it's used in controlling superficial bleeding, especially in third space endoscopy. The other coagulation modes are relatively high voltage modes, and they have some component of cutting too. So they are combined, relatively stronger coagulation with some cutting. In case of coagulation, we have two modifiable factors. Like in cutting, we had 3, but in coagulation, we have just 2 modifiable factors. That is power and the effect. So this picture clearly defines us that soft coagulation is relatively a superficial one, and swift coagulation is on the other extreme with increased depth and increased voltage. There is a newer electrosurgical mode I'm sure the experts here must be using, especially for third space endoscopy. It's a precise sect model. Now, this is a very dynamic mode because it not only helps in dissection, but also helps in coagulation at the same time in a very effective manner, because it is set in such a way that it adjusts current based on tissue resistance. And it depends upon the contact area with the electrical device. If there is a small surface, it will have a dissecting effect. But if there is a large surface, it will have a coagulation effect, hemostatic effect, especially for sealing the blood vessels. The important aspects in sphincterotomy, we usually use endocut mode because it reduces mild bleeding and unexpected zipper effect. Now, data suggests that mild bleeding is higher relatively with the pure cutting mode, but there are no major trials on perforation, pancreatitis, and significant bleeding regarding the impact. Now, if there is active bleeding, it can be controlled like with activation of forced coagulation mode with an effect of 2 and power of 60. So this is just an example, the settings we can use in ERCP. Like if we are using Erbe, it's endocut I with an effect of 2, duration of 3, and interval of 3. So mind you, effect means the degree of coagulation, duration is just the amount of tissue that is cut, and interval is the difference between the two current. For Olympus or similar machines, we can use pulse cut fast with an effect of 2. The same happens to needle knife as well. Effect is the degree of coagulation. So, some important considerations regarding the dispersive pad or grounding pad. Now, the modern grounding pads have dual sensing systems. They ensure that if the contact is poor one, they will not function. So, they should always be placed on muscular, well vascularized area so that current can be disseminated in an effective manner, like flank or upper thigh. We should avoid placing them over tattoos, implants, bony prominences, or scar tissue because of poor conductivity. What happens if somebody has got implanted cardiac device? Obviously, it's always important to check beforehand, and we should use bipolar device because they don't affect ICD. But if we are using monopolar device, there are some important aspects that can always be kept in mind. Number one is use the lowest effective voltage. Second, avoid prolonged activation, and keep electrode like more equal to or more than 6 inches away from the device. So just a summary of some common modes. Endocut Q and I are the blended cutting modes. Forced coag is an effective coagulation mode, especially used in third space. Spray coag, soft coag, we just saw for superficial coagulation. So swift coag relatively gives us a faster coagulation, and it has among the coagulation mode, it has got more cutting as compared to other modes. The precise sect mode is impedance based, we just discussed. An important slide, I think, for all of us regarding the electrosurgical unit in our endoscopy rooms. Obviously, there should always be pre-procedure checkup of the unit. Number one, check for any metals like ICDs, ideal placement of a neutral pad with good adherence. That's very important. Usage of carbon dioxide, especially in luminal endoscopy, and never leave accessory attached to the unit even after the procedure to avoid inadvertent current. Thank you. So Novel will demonstrate few modes live here, but any comment and queries welcome. Okay, so the more the duty cycle, the more the cutting current will be produced. Like if there is 100% duty cycle, we have more cutting. If the duty cycle is 50%, we will have a blended current. If the duty cycle is just 6%, the least, it will give us pure coagulation current. So the more the duty cycle, the more cutting effect will be produced. Okay, so we just saw we have two modes, Q and I. Q is used for snare, and I is used specially for sphincterotomy. No, endocut is a blended cut. So we have 4 settings in endocut. If we use setting 1 with an effect of 1, it will give us a pure cut. The more we increase the effect, the more coagulation will be included. So that's the advantage of using endocut because it's a blended current. It can be a pure cut if we minus the effect of coagulation, but usually we don't. We use it in a blended current manner.
Thanks.
Can I take 5 minutes? I'm sure everybody is very excited and understand every concept, right? Can I connect this? Yeah. कितनी समझ आई है लोगों को? No. That was a very good lecture. So it does not mean in that way. Yeah, so I did not mean by any chair. So a really good lecture of physiology. Excellent. You did a really good job on that. And but translating that into a clinical practice, what we do, it sometimes becomes really difficult. And do we all really avoid this topic? We just want to ask those graphs, what are the settings I should use? That's it. Okay. So I won't take too much time, but main thing is, so I usually, when I give this lecture, this is the first slide I have. Is it an electropottery? No, it's not. Electropottery is when you put your finger on a stone. That's electropottery. This is electrosurgery. It's different than electropottery. And monopolar, bipolar, I think that's a very clear concept we all know. We can understand that. And then it's the same generator which is connected to the wall, right? Outlet. If you put your finger in there, you're going to get burned. But why? Why not this? Anybody? It's the what?
Grounding pad. High frequency.
Grounding pad and what?
High frequency.
Okay.
It is not causing arrhythmias.
Okay. Yes. Why it's not causing arrhythmias?
There is no nerve stimulation.
Why they are not stimulating?
Because of high frequency.
Yes. So it's not a pad. First answer is always the pad, whoever gives. So that's not. It's the frequency. The frequency which comes out of the outlet is 40,000 kilowatts or 60,000. When that frequency increases to millions, those becomes those radio waves. So there are waves everywhere. It's the same. It's just everything is same. It's just what frequency they are traveling at. And electrosurgical unit close to 500,000 kilowatts. That's how much uses. So when you put that in there, you plug this into the socket, the energy which comes out of this is different energy what's coming out of the socket. But every energy which comes out of this goes through the tissue, goes through the body, has to go back to the generator. So there is nothing left in the body. That's why we use that pad. And the bipolar devices, they don't need a pad because there is a circuit which comes back through the same. So that's why they don't use it. Anyway, so their main concept is, we use this word endocut, we use this blended. What's the difference? Really no difference. Why use endocut? What is endocut? Endocut is a trade name or terminology used by Erbe, nothing else. So that's endocut IQ. I don't know what that is. Yeah. Q looks like a snare. Maybe we use it for snare. I look for needle. That's why we use it for that. Like even in the sphincterotomy, it looks like a needle. But the settings which are used, only Erbe engineers know. Nobody else does. They just keep a secret. It's to them. And so they are the only one. Olympus, on the other hand, has this blended 1, 2. All depends on how much the cutting is, how much the coag is. Cutting is cutting. Cutting current touches the cell. It is so hot, the water in the cell boils instantaneously and bursts. That's where you get the current. So that's why it's so clean. On the other hand, coag, when you put that on the cell, it desiccates the proteins. It's slow. And that's why you get that charring on there. So cutting complete is a very nice pure cut. You see the bleeding. Coag, it desiccates so you don't see the bleeding. And that's why we use that for. Everything else is in the middle. Pure cut, pure coag, everything else in the middle. Other thing about the soft coag, such a misnomer. Soft is by no means soft anywhere. It's the most dangerous current. So soft means it's like coagulating it so much, it looks really good. Patient goes home, that desiccation, that plug comes off, they get a perforation. or they get a delayed bleeding. So that's why it's really discouraged to use a soft coag too much. Like heart biopsy forceps, why it doesn't exist more anymore? Because it was using all the soft coag. We only use it when for very few things, but not really a major. So main concept I wanted to show is like, wanted to tell is, what's the difference between pure cut, what's the difference between pure coag, and everything else lies in between. There's one slide I want to show. This one. You see so many names on one slide. So cut, coag, everything else in the middle. And that really depends on how much the current cut is in there and the coag is in there. That's the only difference. So yeah, it's all that physiology, really good, 6%, 100%, all that. But at this level in medicine, I think it becomes really hard for us to understand that. So this slide is the whole electrosurgery we basically use. And this endocut, I've put it in there, dry cut, swift coag, precise cut. Olympus has different, that the blended. So that's basically is like, just needs to understand like, and the effect, there was a question about the effect. Effect is like really, you don't have to leave, like you can have a cut, don't leave any coag in there. Gonna give you an example. Yesterday we did a sphincterotomy. It started bleeding, right? Why it started bleeding? Because when we were doing a sphincterotomy, we were tapping it, not letting the whole cycle of endocut go. Because tap is cut. There's no coag in there. So we do that all the time. And for snare, we put our foot on the paddle and let it keep going because we want it to coagulate. So let the cycle complete. So for if you want to give a coag to the, during the sphincterotomy, you have to keep the foot on the paddle, let the cycle complete. Otherwise, it's not going to provide any coag. So that's basically the concept. Okay. I think that's how much we really need to know. And you can really change the settings. Like the people who do the third space do ESD, they have a little bit more idea about that. Okay, I know I see a lot of fibrosis in there. I need a more cut in there, change it towards the yellow. I need there's a lot of vessels bleeding, change it more to the coag. There's a lot of space, I'll change it to the spray because that has a lot of coag. If I don't have a much space to provide a current, I will go back to endocut or stuff like that. Just like it really, you can change your settings based on what you are trying to do. That's all. Yeah, so color of the paddle mostly like when you are on this side, you're using this, it's a blue paddle, okay? When there is a more current, yellow is more towards the cut. When there's more cut part you want to use, that you go with the yellow. Yeah, modifier in there, yeah. Yeah. Okay.
Yellow for yellow,
Blue for blue. Yep. Okay. Any question about that? Yeah, I think this is a good way to show the current. Like density, you talked about that. Density is also another concept of density is. Density is like all the current, as I said, what comes out of the generator when it goes through the circuit and it has to come back. So it needs to it has to come back. It has nowhere to go. So if the reason the grounding pad works is that doesn't burn, but the snare is burning, right? But the grounding pad is not burning. All the current is coming out of the same place because it has a lot of surface area which is touching that pad So the current is dispersed, it's not as strong. But if it's at one tip, it's going to be really, really strong and do a lot more damage. That's how it cuts it. So for the grounding pad, now there are smarter pads, but if you still have the older pad, gotta make sure it's on completely touching the surface and it's covering a lot of area, because if it comes off and only a part of it is touching the skin, then it's going to cause burn, and that's the same concept which the sneer is. So that's the density. Okay, so it should not be on bony promises. It should be as close to the belly as possible, because you don't want it to put too far and electricity has to travel that far to go back. Then there is a more chances of causing a burn. Okay.
I'll just make a comment here, especially when you are cutting big polyps. Some people have the habit of using wax first to cause blanching, and then that really is misleading because, thank you. The main thing about this blended current is, especially the endocut or Q-cut, is that it has a combination of cycles, as you all heard, and the best way to utilize this is by putting your foot down on the yellow and let it work. Because especially with polyps with big pedicles, as it tends to become coagulated, the resistance increases and it automatically generates more voltage then. And you might get a sudden, like the equivalent of a zipper effect that you make when you get to the big vessels which are in the middle of the pedicle, you just cut through it rather than coagulate it. So that can be dangerous in the sense that it would cause a lot of bleeding. So what we normally advise is that keep your foot down, steady pedal, but at the same time when your assistant or nurse is doing the snare, you use a certain protocol for it, and we use the 5-second protocol. Ask them to count to 1001, 1002, 1003, 1004, 1005, and then complete your polypectomy. Or if it's a big pedicle, then you increase that interval. But you have to do it gradually and regularly. But if you keep on doing the tap effect, you will get the sudden cut effect. So those things are very important. Some people try to do the extra coagulation by changing the pedal from yellow to blue. The problem with that is that you cause so much burn that, as Dr. Khalid Hassan said, you end up with a perforation or extensive tissue damage. So those are the things that you have to be cautious about.
Thank you so much. This was brilliant lectures provided by Dr. Asim and Dr. Khalid. Very tough act to follow. So my performance anxiety is here, and I already have a very bad case of stage fright. So as they demonstrated in their lectures, basically what we're trying to tell you is just know what cut is, what coagulation is, when you would need what, which pedal to press, and what are the settings. So I'm here to practically demonstrate that. If anybody didn't have breakfast, you won't be having any food today because the smell will be awful. ये दरवाजे भी मैंने खोल दिए for ventilation. But just a briefing. There's some misnomers in literature, like when they say vaporization, that basically is the electrosurgical units. Most of the articles you find that mention vaporization occurs at 100 degrees. Technically in English, vaporization means that you're completely eliminating all particles from a substance, and that's vaporization, usually what they show in sci-fi movies. But vaporization in this basically means reaching the boiling point of that tissue for the water to evaporate out. So it's one step behind carbonization, which is basically complete charring of the tissue. What does that mean? All liquid content of that tissue has been removed, and now you're left with a blackish carbonized substance. Hiroshima, Nagasaki is one example of extreme carbonization where temperatures went up to 4,000 degrees, which was the same as the surface of the sun. So there are degrees of burns. So everything that we're trying to tell you is that it's not just this is a burn and every burn is the same. It's actually dependent on the temperature. It's dependent on the exposure time. It's dependent on the resistance of what you're trying to burn. And this is what these settings are all about. If I'm wrong, do let me know at any point. This is something that I'm also learning as we're going. So if I simply start, what we're trying to say is when you hear, you have to hear your pedal. If you're doing endocut on a tissue, you'll hear a different sound.
You need help? You good?
Oh, I'm okay. So basically, you're looking at the effect here. 2 basically means effect. As Dr. Asim and Dr. Khalid mentioned, the effect is basically how much quag you're introducing into a cut. So pure cut means it's like a knife. You're slicing the tissue. It's a pure cut. You've seen it in sphincterotomy. Nice, clean, linear. You don't see much whitish tissue in the surrounding area. I think we saw a sphincterotomy yesterday where we saw the ampulla became quite white because the coagulation was high. So that whiteness of the tissue is basically dehydrating the surrounding tissue, and that increases the resistance. These machines are very smart. They can actually calculate the resistance change in the tissue while you're cutting it, and then they change the voltage accordingly. You don't have to keep asking your tech, or you don't have to keep pausing and flubbering about the machine. It can calculate the resistance as you're burning the tissue, and it does the minor adjustments. Of course, the major ones need to be done by you. So over here, I'm going to use the standard setting. Effect can go up to 6. Mostly institutes will say play with 2 and 3. Every time, if somebody tells you use effect 3, what I usually used to do was just reduce it once, just to see what the difference is. Not really on a live patient. I actually did this experiment, just so I know that when they're saying 3, of course, the manufacturer has a preference. Everybody likes to follow the manufacturer setting, but in our institute, we do try to see what we're comfortable with, and you'll see in most articles, it's up to the endoscopist's discretion. That discretion is basically you experimenting. This is a good experiment. It'll show you the difference. So I'm going to take, as Dr. Khalid mentioned, this is a complete electrosurgical unit, and the circuit is complete. Why? Because this is your generator. I have the earthing pad connected to my piece of chicken. It's lying down on it, and I have my chicken. The circuit will be complete as soon as I come in contact with this. So I have my electrode wire entering the monopolar wire, and it's going to come in contact with the chicken. As I'm doing endocut, I'll be pressing the yellow pedal. Even the colors themselves tell you which pedal to press. And you'll hear some music. I hope you can appreciate 2 kinds of sounds. I'll go again.
And also, you see that when you burn,
ये कैमरा कोई
see that
दिखा
there
सकता है यहाँ
looks
पे?
like a smoke,
वो दिखा?
right?
Okay.
Sometimes you see that. That's not a smoke. That's a vaporized water from the cells. So it like vaporizes so quick, looks like smoke inside, but it's just a water. It's a steam.
So again, I'll show you at 2. Do you see there comes a bit of a pause? Now, I'm going to increase the effect to 4. I don't think you can hear, but I can. The sizzling is a little more. I'll tell you what it did. The pause is more intense. So what happens is, the difference between these 2 effects is basically how much quag am I introducing in between. And it's not that it all of a sudden the current starts dancing in a different direction, it's clogging. It's basically cooling down. There's an interval where the continuous cutting is paused. And that's when that pause allows the temperature of that tissue to fall to a certain degree. So you're cutting at 100 degrees, example. And that music you hear, where the da-da, da-da, you have to listen to it. That is, I know that always makes Dr. Asim laugh. That interval is basically the change of modes. So you have cutting, pause, and that's the waveform pattern you get, an interruption. That interruption is the cooling of the tissue that'll let the surrounding tissue heal, the capillaries to kind of heal. So what's the benefit? If I'm a new trainee and I'm doing ERCPs, I would prefer endocut. Why? Because my sphincterotome will automatically pause a little bit and it'll burn the capillaries of the surrounding tissue. Okay? So as I keep cutting, I won't have a continuous slice. I'll have a little bit of time to anticipate what the next move of the sphincterotome will be. People that do pure cut like Dr. Saad does, he has such a good control of his hand. It's not illegal to do pure cut. It's not like synth police is going to come get you if you did pure cut. You can do it. It depends on expertise. So if you get a continuous slice, you might, as a trainee, if I use pure cut in the first go, I might not have such fine control over my sphincterotome, and I might go creating a zipper cut. Zipper cut with perforation. But pure cuts do not increase the chance of bleed. They're very good currents to use for sphincterotomy. But I like endocut because it gives me a little bit of a pause and I can reevaluate in those few seconds milliseconds, if the axis is correct, if I want to take a pause. I will not do this. A lot of us do this. I'm not letting the music play. Let the music play. Let the machine figure out that as you're cutting, you're creating more resistance in the tissue because it's pausing for clog. When you increase that resistance of the tissue for clog, it allows the capillaries in the surrounding area to kind of burn up. So basically, they form a coagulum. That's what clog does. It causes coagulation. So that's what coagulation does. It causes coagulation. So basically, it's important for you to continuously press it to allow the current to do its job. It'll give you that stop time. And that's what endocut is so good for. If I go for pure cut, is that autocut for Erbe? Yes. Slice. So again, it's not illegal, but clearly when you're doing a sphincterotomy on a small ampulla, you don't want to, as a trainee, find yourself going all the way up and you're not in control of the speed, you're not in control of the axis, you're not in control of the sphincterotome. So that's just my take home from my experience. Obviously, there might be some people as trainees that they're doing pure cut on the first go, but that really depends on you. And that's just my take home for this. Again, it's not illegal to use spray cog. I'll tell you what, if you are doing endocut, you're dealing with voltage of 700 plus maximum. If you're dealing with Swift cog, you're going up to 2500 volts. And if you're dealing with spray cog, I think you're going more to 4000, 5000 millivolts. That doesn't mean that the first pedal you press it's like 5000. You can control that. But what I'm trying to tell you is all of these circuits have been tested on tissue and there are different utilities for each type of current. Endocut can be used, example, in sphincterotomy. It can be used for polypectomy. It can even be used in POEM when you're first making the mucosal cut. When you're dealing with denser tissue that you need to cut through, you can use any type of current as long as you understand what kind of energy it'll provide to you. So everything about this lecture is, if you have a continuous flow of current, all is well and good. But in our field, we're dealing with resistance, different types of resistance. A large polyp, which is 3 centimeters, will have more resistance than a polyp which is diminutive. A small papilla will be very easy to cut, as opposed to a very floppy ampulla where you find it difficult that it's just not slicing fast enough. So you notice that it's a very bulky tissue. And again, in POEM, the different areas that you're cutting, the depth of the tissue, the amount of tissue that you have, you might require stronger force. So that's where the other settings work. So I'll just show you the last type of current, and that's going to be pure clog. Now this means there will be no slicing, it'll just be coagulation. So it's going to be you're going to notice the needle is going to stick to the tissue more. So a lot of the area surrounding the place that I burned is white. And that's because the temperature is lower. I can increase the intensity of that, but it's actually going to cause more surrounding damage. And that's actually very good when you're doing, example, maybe POEMs and tunneling. But again, you have to know the utility of each. You can use it safely, but you just have to be familiar with it. So what we can do is everybody can have a try at this in between. They don't have to have it now, and we can just even start the hands-on. All right, so thank you.
So what will happen now is we're going to go to, we can have two candidates will go to the rooms for ERCP hands-on. Two can go to the models, and those who want to watch can sit here and watch.
Achha, consultants.
So, Nadeem, sorry.
No. I just wanted to sort of make 2 points. One is ERCP and sphincterotomy in a true sense is also a third space endoscopy because you cannot actually visualize. What you can't see is how long is your common channel. Is it 2 separate openings? Is it a long common channel or a short common channel? I think the concerns had been, I think on one hand, the worst nightmare for an ERCP is a pancreatitis or a bleed. So you actually have to decide we don't want to cause any complications, but pancreatitis as opposed to the bleeding. Concerns, and I think I completely agree with that, in terms of a controlled cut, should not cause a significant bleeding. Does coagulation cause pancreatitis? Do we know how big or the long the common channel is? I think which is where you would see some experts would start off with a tap and then they'll put the pedal on. So they'll start off with the initial cut and then go with this endocut, which is a cut, coagulation, just precisely to present that. I don't think it's entirely evidence-based practice, but that's what you would see, and I've actually witnessed and I've seen in the practice where they've started off with a tap, cut, then proceeded with an endocut. I don't think there is any evidence or data behind it, but that's how those concerns or risks been elevated. But it doesn't actually translate into a clinical practice of coagulation causing pancreatitis or a cut causing bleeding. That doesn't happen.
There's one thing that we all know: the more clog you use, the more likely you are going to cause pancreatitis. The less clog you use, the more likely you have bleeding. Whether that will happen or not is something that you can't predict, but those are the general teachings. Personally, I don't like it. I don't want anybody else to control I control my own cut. So I still use the standard the blended cut, and I control my cut. I prefer that.
And what happens like when you get a gap in between those, like that is already cooling it. So again, there's those interval in there. You can increase the interval, but you basically, when you're tapping, you're giving an interval. You're increasing the interval between the cuts, and in interval, you can add a coag by the machine. If you add a coag, that would coagulate it for you. But if you don't add a coagulate, you're giving an interval for it to cool down anyway. So that's why many times I think, I don't know if you use tap or no. I usually use a tap for that reason. Like cut.
I was not happy with when the first time I was told that you can actually cut the machine is going to do for you. I said, well,
Yeah.
I'm going to do it myself.
So it's a.
We belong to that era where this was not there.
No, it was not.
So.
And I think that's the point I was going to make, that with all due respect, you said you belong to that era, but in reality, today's machines are so sophisticated. The whole point of this mixed blended current is to try and reduce some of those concerns about bleeding or coagulation. I actually don't know, Nadeem, how true this is, that too much coag causes pancreatitis. Theoretically, it's a good concept to believe in, just like pure cut causes bleeding. But in reality, I think those events are very rare, especially the pancreatitis from coagulation, because you're cutting away from the pancreatic orifice towards the biliary sphincter. So I think to keep this simpler than even what Dr. Hassan has said, go with your preset in the machine. In most cases, that'll work just fine. There will be very few instances where you'll need to change the settings. And I can tell you from personal experience, that's how life has worked out just fine for me. I may not have the depth of knowledge of these things that you guys have, but most of the time, a simple blended current that they have come up with is perfectly fine for most sphincterotomies. And after that, you do you want to protect against pancreatitis? Better cannulation technique, PD stents, fluids, ice water. Yes.
So all these, they have spent so much time, these engineers, working on this for years and years. That's how they came up with these settings. So it's not like they just.
The reason why we went through all of this exercise was when we got this machine, we have both lumpus and this. And now suddenly we had different. So we started third space. Said, yeah, what the hell is this? And I want to see what are the different things. So these guys actually work.
And I will add that I learned a lot today. To be honest, from both lectures, I think it's
I think when these Erbe machines were introduced,
Plus, obviously, they're so new. They understand the physics, right?
That's the.
All I remember is there's something called current.
Translate that physics into.
Current yarn. Okay, so you can put that up change. I'm going to the model. Okay. So hands-on guys, we are the first one. Do a few have already gone there. You can sit here.